I'm Dr. Jam Khatari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family.
Sally, good evening. It's the end of January, and I think we've officially passed the most depressing day of the year.
Yes.
Which I think is it the third Monday or something? It's like, after Christmas, before payday, and we passed it, right? And as usual, myeloma is throwing us amazing nuggets of optimism, and we're going to get into that with today's podcast. But before that, I don't think I asked you if you had any New Year's resolutions, and I think you can still ask them in January. So what I want from you is one personal one and one myeloma related one in terms of the way you work. There you go. Put her on the spot at the end of January. That's how you got to start the podcast.
Well, you have
today.
Sincerely put me on the spot here, Jam. You really have. So my, I guess my personal resolution relates, like everybody else, to fitness and exercise. And I've fallen foul of that, sort of like been hooked into that industry. So I bought myself a wearable Whoop. Have you heard of these? Which
a Whoop. They tell you your metabolic age, don't they?
Exactly. And that's what got
And I'm not going to ask you what your metabolic age is. Mine is 74, which is cool because I'm actually 87. So that's good.
Well,
that's a good one.
Yeah.
I like that. So good. Yeah. Good luck with the old fitness thing. I think it's a great one. As many people listening may know, when you prescribe these drugs called immunomodulatory agents, IMIDs, you have to do this paperwork called a PAF, a prescription authorization form. And it is the bane of most myeloma doctors' life. Okay. And a lot of people think it's a little bit unnecessary, a bit over-regulatory in 2026. That's certainly my view.
Indeed.
But we have to do them.
Mm-hmm.
And I am just terrible at doing them on time. And I'm constantly apologizing to pharmacists and chemotherapy schedulers. And guys, I am sorry. This year is going to be my year of the on-time path. That is my myeloma resolution of this year. There you go.
That is absolutely
maybe we've done one each. And is that enough, maybe?
It is priceless, I tell you.
I may be the only myeloma clinician in the world who has a myeloma New Year's resolution. Who knows?
Well, who knows?
It's possible.
I mean, you put me on the spot, Jam. I'm going to think of one for next episode. I really am. My mind is whirring, coming up with a blank. So well done for, inspiring us all.
But at a slightly dark time of year in terms of it's still not getting very light yet, and Christmas is gone. Sal, in the UK, in England, we've had some wonderful myeloma related news over the last few days.
I know. I mean, the starting gun's been fired, isn't it? January off the bat, new nice appraisal. I wonder if we're going to get one in February, March, April, May, and so it will continue. I mean, I think that would be pushing it a bit, but brilliant way to start the year, huh? I mean, we had so much activity last year, Jam, didn't we? Which we spoke about on the podcast, but here we are again. It's almost like we have to do these kind of special pods every couple of months, isn't it, when something else comes out? But it's great to talk to you about it today.
It's fantastic. And, they say sequels are better than the original. And, we can talk about The Empire Strikes Back, Indiana Jones and the Temple of Doom. I'm really going off
You're
on
on a
various
roll
tangents
tonight, aren't you, Jam? Yeah.
But the reason that I'm saying sequel is that last year, I think maybe pod number 8 or 9, we talked about Belantamab mafodotin, the so-called Trojan horse chemotherapy. There was a lot of national press around this new drug that was combined with bortezomib and dexamethasone. England and NICE being, the first regulatory authority in the world to approve that combination. And that was last year. This is, in a way, a sequel of that, Sally, isn't it?
Yeah, absolutely. It really is. So we have the next iteration of that. Now, I don't know, it's contentious, isn't it, whether the first of anything is preferable if you're using your film analogy, or the sequel is preferred. I think everyone has their individual.
Part 2.
The Godfather Part 2.
Another one.
I think you've had
The Godfather. I know.
a long Christmas watching a lot of movies.
Let's get back to the topic without me going through endless numbers of movie sequels. Sorry, guys. Sorry.
So it's up for debate, really, whether the second iteration is any better. I think that we have a second iteration of Belantamab with a different combination of drugs here, where you can use it theoretically in the same patient population. So people who've relapsed, having had one lot of treatment before. But instead of Belantamab being bolted onto Velcade and dexamethasone, which we spoke about before, there are different drugs you can now pair it with. And in this case, pomalidomide and our old friend dexamethasone again. So a different sort of partner drug, but a new regimen. And this is still absolutely to be celebrated because it's another option for our patients.
Sally, thinking about it, we haven't talked about pomalidomide a huge amount on this podcast. It's an immunomodulatory agent like lenalidomide and thalidomide, and we've spoken a lot about those agents, but pomalidomide sort of came last out of those three agents, and it's been a very important drug for myeloma doctors over the years. Initially, we used to use it by itself with dexamethasone, which we still do occasionally now, but we know it makes a very nice partner for other drugs, including drugs like bortezomib or anti-CD38 antibodies, and now in this case, belantamab mafodotin.
And I think what we can say about pomalidomide, I mean, the starting gun with the immunomodulatory drugs is fired with thalidomide, and after that, along came lenalidomide. Now, we know thalidomide comes with lots of toxicities. We've spoken about that before, the constipation, the nerve problems, and so on and so forth. But the next iteration is lenalidomide, which comes with different side effects, but perhaps works better than thalidomide. And I think pomalidomide similarly is the one after that. Again, slightly different side effect profile, but may work even better than lenalidomide. And actually, this combination with belantamab is for first relapse when people have had lenalidomide already, theoretically, and maybe even thalidomide too. So it's holding on to the same class of drug, but with slightly different toxicities, and it appears to work really well in this combination.
The trial that led to the approval of this drug was what we call a big phase 3 study, where belantamab was combined with pomalidomide and dexamethasone and compared to another standard combination, which we don't actually and have never really used in England, but actually has been used in Scotland for quite a while. And that's a combination with pomalidomide, bortezomib and dexamethasone, so-called sort of PVD. As you say, this trial, patients had all had lenalidomide, and the majority of those patients, the lenalidomide had stopped working. Is that correct?
Yeah, if you look at the data, then absolutely everybody had lenalidomide. It was part of the sort of entry criteria to get into the study. Well, approximately sort of 4 out of 5 people, they'd been on lenalidomide until it no longer worked, so they were refractory to it. Now, this is really different from the patients who were looked at with the other belantamab combination. So it's very tempting, isn't it? I think we have to hold ourselves back actually sometimes, Jan. We're just saying, well, look at the numbers, this trial did this trial did that, this one therefore must be better or that one must be worse. But actually it's all about the patients that you're actually trialling these drugs on. So this is a somewhat different patient population, but it does reflect really importantly the patients we see day to day who are progressing from first line therapy by and large in the UK. So it does reflect the patients that we might be seeing or that might be coming through in the future.
Sal, when they did this combination therapy, what did the results show, and how long on average potentially could this combination stop myeloma in its tracks for?
Yeah, absolutely. So for all comers, so everyone who went into the trial, what we found, or what the trial found, is that this combination of the belantamab, pomalidomide and dexamethasone controlled the myeloma for approximately, just under 3 years, so about 32.5 months thereabouts, they say. But I think you have to bear in mind that some people in the trial had had more than one prior line of therapy. Some had had 2, or some had had 3. And so actually those patients are going to behave quite differently. And we're only allowed to prescribe this in the UK for people who have had 1 line of therapy. So it may be that the outcomes for our patients will be a little bit different, because the general rule of thumb is if you're getting treatment earlier on, it tends to work for a bit longer. So these numbers are only a guide, and every patient's different, of course. But I think you can roughly say that as a approximate trebling, maybe I'm exaggerating a little bit there, but a trebling of your remission periods with the belantamab added on to pomalidomide versus the Velcade or the bortezomib added on to the pomalidomide, which is great. It tells the same story, doesn't it, Jan? The belantamab is a good drug. It works nicely.
It's also slightly different to the iteration that we talked about last year with bortezomib, in that the typical way in which cycles are given are every 28 days. And that's because pomalidomide, this immunomodulatory agent, is given for 3 weeks out of 4. It's a tablet, and belantamab is given on the first day of every 28-day cycle with that.
Yeah, definitely. So the doses are a little bit different. The dose goes down with the second cycle, or it did in the study anyway. The gap between the doses of the belantamab is also different. But I think it's also, really important to point out that this is in the study, but we know actually from the study that lots of people had extended gaps between the belantamab because of the eye side effects we spoke about before, and lots of people had dose modification. So actually, I think they started charted somewhat differently in the study, but actually it's fair to say for most people being treated with this drug, and by that I mean Belantamab, the dose is probably going to go down and the gap between the doses will probably get longer with time.
So we should touch again on the side effects, and let's start with the eye side effects of Belantamab. This is a clever drug. It's an antibody that has this so-called payload attached. This kind of almost like, little chemotherapy bomb attached to the antibody. And unfortunately, what that little bit attached to the antibody can do, it can cause what we call off-target effects. So yes, it gets to the myeloma, but it can cause irritation in other parts of the body. And the eye is one of the major places where problems can happen. And we know that approximately, over 80% of people will get eye problems.
Thank you for listening to the Myeloma Minutes podcast, proudly partnering with Myeloma UK. For more credible myeloma-related material and support, please visit the Myeloma website at myeloma.org.uk. That's myeloma.org.uk. Or call the InfoLine on 0800 980 3332, which you can find in this episode's description.
In terms of how people feel these symptoms, you can feel the symptom in a number of ways. Your eye can feel dry, you can have blurred sensation, or sort of blurred vision. You can just feel like there's something in your eye, like a foreign body, or just like there's something there, sort of grittiness. Sometimes, the eye hurts. These are not nice symptoms. What we know is that the symptoms are often caused by this thing called keratopathy, where you get inflammation of this lining of the eye called the cornea. A very important thing to say about this side effect is that in the vast majority of people, it is reversible. The key thing is that eyes are monitored very closely before and during treatment, and certain what we call supportive care measures are used. Sally, do you want to touch on those things that we do to just try and keep people's eyes as safe as possible?
Yeah, definitely. So the first thing, as you said, Jam, is before you start this treatment, you go and see an eye specialist who looks at your eyes to check there's no baseline issues with it. And also that's something to compare it to. And then with each subsequent dose, before you're due your next dose, your eyes need to be looked at again. And they're assessed objectively to see how bad this potential damage to the eye can be. And if there is damage there, and actually even when we first start the drug, we offer lubricating eye drops to kind of help with that soreness that can occur in the eye that you've spoken about, that sort of grittiness. And it's very, very common to pause the treatment to enable the eyes to heal and get better. And then you can go back and start it again. So it's really important to say with this drug that more is not more. You can give less of the drug, and the studies show even when you give the drug less frequently at a lower dose, people fare just as well. So this isn't a put up, shut up, you've got to handle this horrible side effect. As you said, Jam, it gets better and near enough everybody. Use your eye drops, go to your appointments. When the person assessing your appointment says, actually, your eyes are struggling, you've got a certain grade of keratopathy, which is a medical way of sort of saying it's this bad. If it's a certain grade, which is grade 2 or above, you just need to pause for a bit, wait for the eyes to get better, and then you'll more than likely go back on the treatment at a lower dose. So yeah, generally I use eye drops. People do sometimes, I don't know if you've noticed this, like to wear sunglasses, they do suffer with this phenomenon called photophobia, which means that the bright lights sort of dazzle them a bit and it's hard to see. And that actually can be particularly problematic when driving at night, because the glare of the sort of of the car lights can really make it difficult. So just a shout out to be aware of that. But yeah, that's what I tend to use. I suspect you're the same, aren't you, Jam?
Yeah, very similar. Preservative-free eye drops are extremely important. In terms of the logistics of where these eye tests are done, in some hospitals, it may be done in-house, and you may have optometrists or eye specialist doctors, ophthalmologists who do this work. But in lots of places in England, there is an agreement with a well-known brand of opticians, and people are going there for their assessments, and they're sent to the doctor. We can make those decisions on whether to reduce the dose or delay. And as you said, Sally, I think this is really one of the first drugs where we've shown that very infrequent dosing can still lead to excellent outcomes.
Definitely, which is a win for the patient. And actually, if you look at the study data as well, and the studies do tell us a lot, what you tend to see in terms of how people feel and what we call their quality of life is that actually this is with the bortezomib combination in particular. There may have been a dip of their quality of life, but it picks up, and that tends to coincide with when you have the doses less frequently, your eyes aren't that bad and you're carrying on with your life, but the treatment's still working. And it's quite nice like that, really, Jam, isn't it? I think if we think about saying to our patients, you might need tablets, you might need injections, but actually this injection, you may only need every 10 to 12 weeks. So, that's kind of lovely. But that does bring me actually just to think about the difference between the two regimens, Jam, the regimen with belantamab containing Velcade or bortezomib and this one. I guess one of the key differences from a patient perspective is that the Velcade or the bortezomib bit stops after a period of time, whereas with the pomalidomide combination, you keep on taking the tablets. And I wonder if that might affect the choices that we present to people or the choices that our patients make in terms of these regimens. What do you think?
Yeah, no, I think that's a really important point. And I think now's a good point to talk about the other side effects of what happens when you combine belantamab with pomalidomide. Now, I think one of the strengths of pomalidomide is that in terms of the side effects that people feel, it is, really one of the best tolerated drugs we have in myeloma. We do know that it can make your blood counts go down, and with that comes an increased chance of infections. And certainly when you combine pomalidomide with belantamab, there is no doubt that there is a not insignificant risk of serious infection that will partly be related to people having issues with their blood counts, but also just the generalized effect on the immune system. And as you say, the pomalidomide is something that is continuous and may impact how doctors think about continuing the drugs or reducing doses or thinking about alternative strategies. So if you're in the position where you may be starting this combination, the eye side effects are top of the list, but you have to think about infections as well and low blood counts. Any other side effects, Sal, that we should inform people about?
Yeah, something I really keep an eye on, I don't know if you're the same, is platelet counts actually during the first cycle of treatment in particular. That can be really problematic. So just to remind our listeners, platelets are really important, tiny little cells that help our blood clot. Aspirin, for example, stops them from working so well, and that's how it sort of thins your blood. But we know that the belantamab, in combination with pomalidomide actually and Velcade, whichever regimen you go for, you might get a fall in your platelet count, and we always need to be mindful of that. My clinical experience is that's always been most marked during the first cycle, but that is something that plays on my mind, as well as sort of those overall symptoms of fatigue and, as you say, chest infections, particularly with the pomalidomide. What it is really important to say, again, about both combinations is they're safe with people with renal impairment. So you don't need to necessarily dose adjust, in a way that you might have to do with some other drugs. So you can give this to the majority of patients. And it's lovely to have a choice between, well, this person's got a bit of neuropathy, so I won't give them Velcade or bortezomib, I'll give them pomalidomide. Or rather with pomalidomide, you might say, well, this person's got lower blood counts, so I'll try the Velcade instead. And another really important factor, I guess, in terms of decision making is with the Velcade, it's a subcutaneous treatment, meaning that it's given under the skin. Tends to be given, I think, in most places once a week, but that's once a week for a number of months. Yeah. Whereas with the pomalidomide, it's a tablet you take at home. Now, you have to be on it continually, but you don't have to turn up so much. So it's kind of a careful conversation about what might suit the person best and what they might prefer as well. But I think they're really, it's very common side effects, these, Jam, aren't they? For us anyway, we're very familiar with them, I think.
Indeed. And hopefully that means that we can minimize the risk of them causing problems. So Sal, if we're thinking about, and this is a sort of, I guess, quite a sort of England-centric conversation at the moment, for people who've had lenalidomide in their first treatment, which increasingly is, lots and lots of people, and the lenalidomide has stopped working or people can't tolerate it for whatever reason, they potentially would be offered the combination of belantamab with pomalidomide and dexamethasone, which we've been, of course, talking about for the last 20 minutes, or assuming that they are still sensitive to this drug Velcade or bortezomib, they might be offered the other belantamab combination. So they could potentially be offered either, and really the sort of last 10, 12 minutes sort of discussion, maybe the things that they discuss with their doctor? I
think so, yeah. And it's really worth spending a bit of time just trying to sort of get your head around this if this is coming up. And I'm sure most teams would give patients advance warning where they can that this is something to consider, so they've got enough time to think about it. These are the pros and the cons. One is tablets, but you have to stay on them for a while. The other is turning up more frequently at the beginning for an injection, but that ends. The belantamab dosing, I would suggest, generally with time becomes much of a muchness, and the side effects from the belantamab are going to be very similar, whichever combination you go for. So it's just figuring out the right fit, really, Jam, and I hope that the medical teams, and particularly actually the specialist nurses, can guide us through that together.
It gives more options and increased choice, which, has to be a good thing. We're getting more confident about working with our ophthalmology and our eye colleagues, understanding the data that comes from them and what we need to do. And as people stay on these drugs longer, it gives us more confidence to combine them and understand, what may be the best combination for any patient.
Yeah, completely agree. Great to have both options. It's fantastic to be able to have these complex discussions. And actually, to our listeners, I think we often say this, don't we? We hope that we're helping guide you through this part of your journey as well. But let us know if there's anything extra that you'd like to know about this. And before I forget, Jam, there is one really important thing to say about belantamab, and I hope we mentioned it in the last podcast as well. And I say this fiddling with my eyes, is that you can't wear contact lenses. So for our listeners out there who wear contact lenses, just know that's a potential problem, because obviously the last thing you want is a contact lens on top of a sore eye. It could really be problematic. Yeah. So really practical stuff like that, driving, contact lenses, being out at night, what you do day to day, that really does need to be taken into account.
Indeed, it does. Thank you, Sally, for highlighting that. Fantastic to, start January with a new approval and a new combination, belantamab, pomalidomide and dexamethasone.
Yeah, brilliant. I mean, I think we both were a little bit excited about this pod, Jam. I think we've had lovely diversions talking about movies and all sorts, but it's really fantastic to end on a high as we say farewell to the darkest month of the year, January, to celebrate the achievements of NICE and the communities and the pharmaceutical companies and the trialists who've really helped get this great combination to patients. So another option for our patients in the UK and hopefully beyond in the future for people who are relapsing off first-line therapy. Something that works really nicely, appears to treble how long people stay in remission for, and hopefully with side effects, as we've explained, which are manageable. I look forward to prescribing this in practice. I'm sure it's the same for you. Good times ahead.
Another protocol to write, and we're already on it. Lovely conversation. And to everyone, thank you for listening. The next episode, we're going to start talking about CAR-T, and I'm really excited about that.
Yeah, exciting stuff. Looking forward to that one, Jam. It should be fun.
Thanks, Al. See you at the next one.
Take care. Bye.
This has been the Myeloma Minutes. We hope you found this week's pod engaging, interesting, and above all, understandable and genuinely useful. If you enjoyed today's episode, please follow the podcast and share it with anyone who might benefit, from your online support group, your medical team, to friends and family. And as always, if you have questions or topics you'd like us to cover in the future episodes, please do get in touch. You can find us at www.themyelomaminutes.com or email us at themyelomaminutes@gmail.com. And you can find us on social media by searching The Myeloma Minutes on Instagram and Facebook. Many thanks for listening, and we'll see you at the next one.